Thank you, Becky, and thank you, Upper Midwest TRC, for hosting and providing the platform for this event. My name is Meg Kwong. I'm the Senior Policy Associate at the Center for Connected Health Policy. We're the National Telehealth Resource Center. We work with the regional TRCs to provide technical assistance to people who have questions regarding telehealth, either programmatically or on the policy side or on the technical side. So I am just going to start with a couple of slides here. Let's do this. Beginning. There we go. This is a series of webinars that the TRCs hold once a month. It's the third Thursday of every month, and it's on a variety of topics related to telehealth. Just very quickly, there are 12 regional telehealth resource centers that cover the entire United States. If you're in a particular state, you have a TRC that works on your behalf. What the regional telehealth resource centers do is they're more on the ground. They provide technical assistance on a programmatic level, although many of them are very savvy as far as policy issues are concerned. But if there's a reason they may need extra help on the policy side or on the technical equipment side, there are two national centers as well. One is for technology, that is the TTAC, and then on the policy side, that's us, the Center for Connected Health Policy. Just really quickly, what we are is we're a nonprofit, we're an independent public interest organization that looks at advancing state and national telehealth policies to promote better care and improve health outcomes and provide greater health equity across the board. We are a program underneath the Public Health Institute, and we've been the National Telehealth Policy Resource Center for a little over 3 years or close to 3 years. What we also do is we do other projects unrelated to our federal grant that provides us to the opportunity to do work as the National Telehealth Policy Resource Center. And one of those grants is related to looking how telehealth could be used more on the public health side, particularly in the treatment of infectious diseases. We have been working with Dr. Garfien to look at how telehealth technology could be used to better treat or more effectively treat tuberculosis, particularly around medication adherence and direct observational therapy. So just a little bit of background, Dr. Garfien. Dr. Garfien is a professor of medicine at the UC San Diego School of Medicine Division on Global Public Health. He received his doctorate in infectious diseases epidemiology from Johns Hopkins University and his master's of public health from UC San Diego State University. Before joining UC San Diego in 2005, he served as an epidemiologist for 8 years at the U.S. Public Health Service at the CDC. He has over 2 decades of research experience conducting observational interventional studies in the U.S. and abroad. Dr. Garfien? Richard, I think you need to unmute your mic.
There it is. Okay. I was pressing on the little picture, not on the mute button. Thanks for that introduction, May. I appreciate that. Well, I will just go ahead and get started by sharing my slide presentation. So today what I'm going to be talking about is the use of telehealth technology to monitor tuberculosis treatment adherence. And we're using this technology for the disease tuberculosis in particular, but that's not to say that this technology doesn't have applications for other infectious and non-infectious diseases. So just keep that in mind during the presentation that, that we'll specifically be talking about TB, but this could be applied elsewhere. Just to give you an outline of what my talk will be about today, I'm going to give you a background on tuberculosis, talk a bit about TB treatment and the need for monitoring adherence and why that's so important, and then to discuss some of the technology solutions for monitoring adherence. And then I'll describe our application, which we call Video Directed Observed Therapy, or VDOT. And then I'll give you some of our research findings from both our studies and from other studies. And then I'll conclude with a little bit about the health policies that are involved in working with mHealth. So as background, tuberculosis is an infectious disease caused by the bacteria M. tuberculosis, and it's spread from person to person through airborne contact, primarily when people have close contact with somebody who is coughing or sneezing. And TB is found pretty much all around the world, although it's definitely concentrated in some parts of the world, such as Asia and South Africa and parts of South America. But approximately a third of the world's population is infected with the bacteria. The majority of those individuals have what's called the latent form of the infection, so they're not infectious, they're not ill, but at any point in their life, if they should become immunosuppressed, the bacteria could wake up and cause the disease. TB is one of the world's deadliest infectious diseases. We don't hear a lot about it in the US, and I'll tell you why in a moment. But around the world, it's quite a big problem. There's 1.1 million cases of TB worldwide today, and 8.8 million new cases each year are reported to the World Health Organization. And this infection leads to 1.5 million deaths annually. So it's a considerable problem. And to bring it a little bit closer to home, if we look at the United States, in the US we have about 10,000 cases a year, and the incidence is, okay, I gotta move all your lovely faces off my screen so I can see my whole screen. So the incidence rate is about 3 per 100,000 population. And in Mexico, the incidence rate is about 16 or 17 cases per 100,000. But if we look at the border states, on average, the incidence rate is higher than the national rates. And when we look specifically at the, come on, there we go. If we look at the incidence rates in each of the states, we can see that California and Baja California have the highest incidence rates of the US-Mexico border states. And in the cities of San Diego and Tijuana, we have some of the highest rates in both countries. And so that was one of the reasons that we became particularly interested in TB here in San Diego. And TB is not an insignificant problem. It costs on average $5,000 per patient to treat a patient in developing countries. Obviously, it costs less in, it costs about $5,000 per case in developed countries and less in developing countries, but still a big cost. And as an example, in San Diego, we spent nearly $9 million per year just to treat our 300 or so cases of TB in San Diego alone. And that is only the medical costs. That doesn't include the patient costs, such as lost work or productivity. So the good news is that TB is a treatable infectious disease, and 90% of cases can be cured with first-line antibiotics. The thing is that adherence is incredibly important, because if patients are non-adherent to their medications, if they're starting and stopping or stopping early, the bacteria that have mutated and formed resistant strains have an opportunity to proliferate and become the dominant strain. And then those strains can actually cause the patient to become sick all over again, and those strains can be transmitted to other patients. And when you have these strains of TB, the treatment becomes much more expensive, it takes longer, and it's more toxic to the patient. So why don't people take their medications? The main reason is that it's a very long treatment duration. It takes a minimum of 6 months and can last up to 2 years if you have a drug-resistant strain. The medications we typically treat with at least 4 drugs to make sure that if the bacteria mutates against one drug, there will be some other drugs on board that could kill the bacteria and prevent the development of drug resistance. And these medications are, some of them are hepatotoxic, others cause other nasty side effects like upset stomach and itchiness and a lot of other things that are uncomfortable. So when patients start treatment, they're obviously very sick and they're willing to take the medications because it's making them feel better. But after the initial symptoms of the disease reside, the patient is still required to take medications for many more months, and then the treatment actually seems worse than the disease. And so it's very difficult to get patients to stick it out for the whole course of treatment. The drug-resistant TB is a growing problem worldwide. There's now actually been cases of TB that have been reportedly resistant to all classes of antibiotics, which essentially puts us back in the pre-antibiotic era when it comes to treating TB. We've seen extensively drug-resistant TB in pretty much every country where it's been looked for, including the United States. And we had a case of that just recently in the news, and that patient's being treated at the National Institutes of Health right now. So even though we don't have a lot of TB in this country, drug resistance does affect us, and making sure the patients continue to take all their medications until they complete treatment is incredibly important. So how do we accomplish that? Well, the way that's been decided upon by health agencies around the world is a system called directly observed therapy. And this is where the patient is asked to take their medication in the presence of a health worker or possibly a family member who's designated as a treatment monitor. And this can take place either in the patient's home, where the dot worker goes to visit the patient, or the patient can be asked to visit the clinic. In San Diego, we have dot workers visiting patients in their home or at their place of work. In many other countries, including Mexico, it's up to the patient to find their way to the clinic every day to take their medication, and you can imagine how difficult that could be. But because of the fact that it has been shown to improve adherence, the CDC and the World Health Organization both recommend DOT whenever possible. And it's really important because it reduces the risk of acquired drug resistance. It prevents treatment failure, and it prevents relapse of TB disease once people have completed treatment. Also, by making sure that patients don't miss doses, you can space out the doses a little bit further, and it makes it easier for the patients to take their regimens. And it can also reduce the total number of doses the patient needs to take. Studies that have been done on DOT have actually shown that it has been quite effective in saving lives. So that's the current standard of care. And so what we're trying to do is accomplish DOT wherever possible for the treatment of TB. And the main purpose, just to summarize, of why we monitor treatment of TB is to document that all the doses were taken, so the doctor and the patient know when treatment is actually complete. Also to promote treatment completion and make sure that patients don't stop early, and also to detect any side effects that might be occurring from a patient who's might be having some toxic effects from the medication. But ultimately the goal is to reduce TB morbidity and mortality, to prevent TB transmission to others, and prevent the acquisition of drug-resistant strains of TB. Now, DOT sounds good, and it is recommended. It's the standard of care, but there's actually many barriers that prevent people from using DOT. In particular, it's the cost. We have to pay for staff to monitor the patients. It requires transportation either for the patient or for the providers. It can be impractical in some rural settings if the patients live far away from the health centers. They can't be visited. And it requires coordination between the patient and the provider. So both parties have to be present at the same time. So that means that it doesn't usually take place during holidays or off work hours. And then there's this problem of mobility and migration. If patients are moving around, it's hard to monitor their care. And an important consideration is that when the dot worker is showing up at the patient's home every day, it can cause the neighbors to ask questions. And TB remains a highly stigmatized disease. So the process of DOT can actually impede people from taking their medications. And finally, there's patient autonomy. Patients, after a while, they get tired of having somebody hold their hand, and they want to be able to do this on their own. So there's been some attempts at using technology as a way of monitoring patient medication adherence. Some of these are based on biological measures such as blood tests or urine tests, and they're effective at reading the amount of medication in the blood or the urine. However, they're really not very good at monitoring the continuity of treatment. So if a patient doesn't take their medications until the day before they come for their doctor visit, the test would look like the patients are being compliant when they're really not. So there's been a new generation of devices that are flooding the market, and these tend to be reminder systems or things like pill bottles or pill dispensers that are very good at helping the patient to remember to take their medication and tracking whether or not they open the container. But none of these are at all effective in knowing whether or not the patient actually put the pill in their mouth and swallowed it. So that sort of brings us back to the concept of directly observed therapy and watching patients take their medications. And so in some places back around a little over a decade or so ago, some health departments were starting to experiment with using telephones with video cameras on them to basically replicate the DOT process from afar. And in particular, there was one early pilot study that was done in Washington where 6 patients were followed for up to 6 months using the phone. Basically, the patient had one of these phones installed in their home. The health department had one at the office, and every day at a specific time, the dot worker would call the patient and ask them to turn on their phone and then show the medications and take the pills while they're visible on the screen. And then the dot worker can document that they actually took the medication. And using this process, they found that the adherence was very high for these patients. The patients actually enjoyed it. They found that it was easy to use. It was a lot high satisfaction. But importantly, it saved $1,800 per patient in staff hours and mileage. So this was seen as a success for this pilot study. And then in San Diego, a few years later, a similar project was initiated, and I think there was about an $8,000 investment in these phones to treat 33 patients over a 9-month period. And what was found was, again, that there was very high acceptance for this technology, and it saved about almost 30,000 miles in travel and almost a half of an FTE. So it's really was found to be quite cost-saving and feasible. Another study analysis that came out of Washington using a larger sample size found that the average cost savings per patient was roughly $2,500. So even if adherence were exactly the same with video DOT, these methods are much cheaper and would allow health departments to stretch their limited resources further. Now, what's happened, though, is that the fewer and fewer patients are actually having landlines in their home, and this technology is becoming obsolete because everybody's using mobile. And in fact, 2002 marked the turning point where mobile telephone subscribers overtook fixed line subscribers worldwide. And you can see that some of these countries, like Mexico, have more cell phones than they do landline phones. And more recent data from 2012 shows that this trend is really continuing. And in developing countries such as sub-Saharan Africa, they've basically leapfrogged over the whole fixed line system and have gone directly to mobile. So we said we need to come up with a solution that accomplishes the same thing, but on mobile devices. And that's where our research started here at UCSD. And so just to give you some terminology, video DOT is what we refer to when we talk about using a mobile device, a phone, to have a dot worker watch a patient take their medication remotely. And when it's a real-time streaming video, such as Skype or FaceTime or a web conference like we're having right now, we refer to this as synchronous video DOT or VDOT. And when the patient makes a video of themselves taking their medication, and then that video is sent to the dot worker to watch at a later time, we call that asynchronous video dot. Some people refer to that as store and forward. So I just want to make that distinction between sort of live streaming and recorded video dot. They're both accomplishing the same objectives, but one is live and one is recorded. There are some other technologies out there that you should be aware of, but I'm not going to talk about today. One of them is ingestible sensors. Basically, it's a chip that gets placed on a tablet, and when the patient swallows it, it triggers a sensor that can detect that the medication's been swallowed. There's also some software that can be used on a computer that can see the patient swallowing the pill, and the computer documents that the medications were taken. But going back to the video dot, in a just to give you some data on the effectiveness of video dot using mobile devices now, there was a study done in New York City using the synchronous form of video dot. And just in this pilot study, they found that that VDOT is a promising supplement to face-to-face DOT. So rather than replacing in-person DOT with video dot, they found that this works quite well for many patients as a nice option if they can't do the in-person DOT. They found that patients were highly receptive to using the live video dot. Most patients selected the live option over in-person DOT for privacy or for convenience. It eliminated a lot of the time restrictions of when they could take their medications, because they didn't have to rush over to the health department or have someone come to their home. And adherence was quite good. And what they also found was that one observer could watch 25 patients daily, which usually would take 2 to 3 people to accomplish in the field. And the important part is that over 92% of the patients in this study had adherence rates of greater than 80%, which is what the CDC would consider successful. So just to kind of give you a little bit of more of the insight on the use of the live streaming form of video dot, when patients were asked why they selected the live VDOT over in-person DOT, most said that it was because the method was convenient or it accommodated their work schedules or school schedules. A few patients said that it saved time with travel. It was more private, and that by being able to take their patients at home, it was more convenient. And then there were some patients that, they also looked at why patients stopped using video dot, and for the most part, it's because they completed treatment, which so many patients got all the way through it. A few patients, it turned out, did not have TB, and so medication was stopped after the final test results came out. A couple of patients did have some problems. A couple of patients lost their phone, or later on changed their mind or moved away and couldn't complete it. And there was one patient out of 37 who stopped because of low adherence rates. So the point of this is that, again, video DOT works for a lot of patients. It makes their life easier, but it's not a panacea, and it shouldn't be considered the only option. And then something that's very important to consider when we talk about the live form of DOT is that because it requires both the provider and the patient to have a consistent connection to whether they're using the internet or cellular connectivity, they have to have a reliable connection to the other party. And so they looked at this, and out of the patients that were in this study, the most frequent problem was that they couldn't hear. There were audio problems with the video interaction. Also, sometimes the videos would freeze up and they couldn't finish the interaction. There were typically connectivity problems at the patient's location. or the conferencing program wasn't functioning right. Occasionally, a patient didn't charge their phone, so they couldn't do the interaction when the dot worker called them. So connectivity is an issue, um, and and sometimes the patients had some problems actually managing the phone. But an important consideration is this issue of connectivity with the live form. To give you a little bit more data on the use of live video DOT, there was a study in Toronto that found that VDOT visits, which included travel time and to document the event, uh, took about 10 minutes versus 36 minutes for a home-based DOT visit. So it took about a third the time to do video dot as it would take to do in-person DOT. Then in Illinois, a study was done, and they found that it saved an average of 9,500 miles of travel per patient. So we're talking about 6 to 9 or 12 months of treatment for these patients, and that adds up to a lot of mileage. And they also found that it only took about 5 minutes per session to go through the interaction by video dot. So again, it sort of really reinforces that doing this remotely has a lot of benefits. Now, what we did at UCSD was we tried to overcome some of those problems that I just explained with connectivity and the patients not being able to take their medications at the time that the dot workers were available to watch them. And so we developed an application at UCSD in-house that would allow the patients to record the video on the phone, and then when the connection was good, either through cellular or Wi-Fi, the video would automatically upload to our server, and it would sit there until the dot worker either came in on Monday morning or later that day and was able to sit down at their computer and watch the patient take their medication. And when they saw the video, it would look something like this. So as you can see, to do that interaction, it takes the patient about a minute, and a dot worker who's watching it can check off that that patient is done very quickly, and then get on to the next patients and get back to the clinic where they might be needed to take care of other patients. So that's sort of a typical video. Some take longer, some can actually be faster, but that's the process. Then once the dot worker has watched the video, they can document what they see. And if no video comes in, then the dot worker knows to contact the patient to find out what happened. So the technology is one aspect of this, and it's working quite well. We're still working through some kinks. But the other part of this that's quite important is the training of the dot worker and the patient to make sure that the interaction that's being observed is exactly what needs to happen in order for the dot worker to feel with the same level of confidence the patient took the medication as if they were actually in person. So with this technology, we conducted a pilot study in San Diego and Tijuana, Mexico, to sort of get a sense of how this would be received in both a high and low resource setting. And so we enrolled 41 patients in San Diego and 9 patients in Tijuana. These are all cases of pulmonary TB, nothing unusual about them. They weren't drug resistant or terribly difficult patients. And we gave them the phone, taught them how to use it, and then allowed them to make videos until they either completed treatment or got switched back to the in-person DOT. And what we found was that in San Diego, of the videos that we expected to receive showing a patient taking their medication, 93% of the videos were received. So in other words, we had a 93% adherence rate using VideoDot in San Diego, and it was actually better in Tijuana at 96%. We also included a questionnaire that we asked the patients after they completed treatment, and when we asked how often they had problems recording videos, the majority of the patients actually said rarely or never, so they found it quite easy to accomplish. We also asked if they found one of these methods, VideoDot, more confidential than in-person dot, and the majority said it was more confidential. A few people said there was no difference, and only 4 patients said that it was less confidential. And when we inquired about those patients said they just didn't know who was watching their video, and they felt a little uncomfortable about that. And then we asked the patients, if you had to redo your TB treatment, would you choose video dot or in-person dot? And the majority said in-person or video dot. Only a couple said no preference. And one patient did say that she actually preferred in-person DOT over video dot. And, you know, and that, again, just goes to show that if we're going to be client-centered or patient-centered, we have to be able to provide patients with multiple options for treatment. And then we also asked, would you recommend video dot to other TB patients? And 100% of them said that they would. And then we also asked, as a result of participating in the study, are you more comfortable using a smartphone than you were at the beginning? And the majority said they were more comfortable. Some said that there was no difference. But this sort of highlights that once you introduce patients to using technology for medical care, they become more adapted to it, and they could potentially begin to use it for other illnesses as well. So we're sort of training the population to become more tech savvy. In terms of the cost, we looked at the cost in both San Diego and in Tijuana. And when we talk about the cost of VideoDot, this includes staff salaries for implementing it, training patients, etc. There was some transportation involved because in the beginning, the dot worker did need to go to the patient's home to teach them how to use it. And if there were ever problems, they would troubleshoot in person. And this also includes the cost of phone service. The only cost that's not included is any cost for using the VideoDot application itself. And then for home-based care, we used records from the health department to figure out how much the staff salaries and transportation would cost. And what we found was that in San Diego, the cost for in-person DOT for an average 6-month course of treatment would be about $4,100. And with VideoDot, the cost was $1,300, so about a third of the cost for VideoDot. And the same was true for Tijuana. Although the dollar amounts were less, it still came out to be about a third of the cost. So what we found is that VideoDot can be cost savings for health departments. So even if you have to change the add technology, the savings in terms of manpower are substantial. And then another analysis was done using the same technology with a study in San Francisco. And again, they looked at video DOT, clinic-based DOT, which is where the patients would come into the clinic to receive their medication, or home-based DOT. And home-based was the most expensive, obviously, because of staff time and transportation. The clinic-based was less, but also had costs because the health department provided the patients with some assistance with transportation. And then even when you consider the phone plan for the phone, VideoDot was the least expensive method. So in conclusion, VideoDot provides DOT at a lower per patient cost than in-person dot due to the reductions in staff time required to provide dot, transportation costs, and salary of the staff providing VideoDot compared to those providing in-person dot. And then this is to let you know that we've actually expanded our research to now include San Diego, San Francisco, and New York City to see if we were going to get the same results with a larger sample from more parts of the country. And this table is sort of full, but it really is just there to show that the cases that are enrolled are representative of TB cases in the country. and that we have a good variety of age, race, sex, gender, and one thing that was interesting is that we found that almost 80% of our participants actually had insurance, sorry, and that the majority already had a cell phone to begin with, and about 2/3 of them had a smartphone. So in the US, TB patients tend to be already pretty tech savvy, although not all of them do. I'd also like to just point out that we've had patients in our study as old as 87 years old, and those individuals were able to manage to use the video dot as well as some of the younger patients. So age should not be a limitation. And what we found so far from this study is that, again, the adherence rates are very high. The majority of the patients have, 90+% adherence. We do have a few patients that were having some difficulty. Some of this could have been due to technology. Others could be because the patients were just non-compliant anyway. And then when we looked at preference, again, asking patients if they prefer in-person to video dot, we had one patient who preferred in-person DOT. The majority preferred video dot or didn't have any preference. And then in San Francisco, the staff there actually were queried to find out what they thought about video dot. And what they found from the survey was that the nurses said that for patients, video dot has made TB treatment by and large easier. Some said that there was no change in their treatment compared to in-person DOT, but none of them said that it was made their treatment more difficult. And then they also asked how video dot has made treating patients at the TB clinic, how effective treatment was. And there was a case or two where they were having some difficulty, so it made it less effective. A few patients, there was really no difference between in-person DOT and video dot. And that was sort of my point earlier, was that even if video dot has the same level of effectiveness as in-person DOT, but it could be delivered at a lower cost, then there's actually a benefit to it. But for the majority, they said that video dot was more effective for treating their patients. And one of the TB nurses said that patients have busy lives and often cannot come to the clinic. VDOT facilitates treatment without the inconvenience of coming to the clinic. And for staff, there are less patients waiting in a congested, busy clinic. So they really saw this as a plus. So now I just wanted to wrap that up by giving you a couple of examples of the other technologies out there, like these ingestible sensors. You can see there's a tiny little microchip that gets put on a pill. Then there's also the facial recognition applications that you may see that could also be used for monitoring pill taking. And if you search the internet, you can find examples of those. To wrap things up, I wanted to just talk briefly about the legal environment for using telehealth, at least in California. Well, what the current situation is that TB-related services are reimbursable as a fee-for-service in California, which means that health departments that do use DOT can be reimbursed $19.23 per encounter. So that helps them to recuperate their travel costs, et cetera. But currently, EDOT is not reimbursed, can't be reimbursed. So if health departments want to switch from in-person DOT to video dot, they might be saving money, but they're also going to be losing that reimbursement. And so Medi-Cal in California has indicated that it could be possible to change the interpretation, but evidence is needed to before that decision could be made. And May could talk more about this later, but the California Telehealth Advancement Act of 2011 expands the types of eligible telehealth providers that can deliver treatment through telehealth. It eliminates restrictions on acceptable telehealth modalities, such as what type of device is being used. It eliminates restrictions on where it can take place. And any changes can be made, these changes can be made without legislative order. But it's not to date, the video DOT is not a reimbursable act. So the Center for Connected Health Policy is actually working on this issue, as May had indicated in the beginning. One of the things that's sort of holding up acceptance of video dot by health departments and potentially by insurers to pay for it is that there does not exist good guidelines on how to implement VDOT programs yet. CDC and the National TB Controllers Association published treatment for TB guidelines in 2003, and it only refers to in-person DOT. It doesn't talk at all about video DOT. And then the state of California Health Department of Public Health and the California TB Controllers Association published joint guidelines in 2011 for delivering directly observed therapy. And this document actually has a couple of paragraphs in it that define video dot and considerations for its use and one sample protocol, but it doesn't really go into detail about how to do that. So the UCSD and the Center for Connected Health Policy got together, and we proposed to the California Healthcare Foundation a project or some parallel projects to actually address this issue. And so the purpose of our projects is to inform health policy and develop best practices for expanding mHealth in California. And the collaborators on this project are UCSD, the Center for Connected Health Policy, the California Department of Public Health, and 5 health departments around the state. And so the objectives of the study that we're doing are to determine whether video dot is as reliable as in-person DOT for observing medication ingestion. Also to determine whether video dot can be applied in both low volume rural and high volume urban counties in California, and to estimate the patient and provider costs associated with video dot, and to develop these best practice guidelines for use of video dot throughout California and potentially to be expanded to other parts of the country. So these are the objectives of the project that UCSD is conducting. And the goal is to provide evidence to support changing these health policies. So I'm going to skip through this. This is just the description of our research study, but for the sake of time, I'm going to skip over that just to let you know we are conducting ongoing research to get the evidence to show that video dot is cost effective and efficacious. And then the Center for Connected Health Policy has research aims as well, which include describing the current legislation, policies, procedures, and practices related to TB control and compliance at the federal, state, and county levels. And they've got some really great information on their website. To assess the acceptance and concerns among federal, state, and county officials regarding the use of video dot compared to in-person dot, and to produce recommendations for future use, and to develop and or refine policy recommendations for state and federal agencies governing the use of video dot, including the potential for expanding Medicaid or Medi-Cal reimbursement for VDOT, and finally to assess the application of video dot for other infectious diseases. And the way that they're conducting their research is by interviewing providers that have used video dot or have never used it, and also talking to people who haven't used video dot in the past, and to talk to policy experts on Medi-Cal and Medicaid. They're planning on conducting literature reviews, interviewing individuals, and surveying stakeholders such as the TB control program officers from all the counties and states. And the deliverables from their project will be a white paper, providing presentations, writing journal articles, issue briefs, and conducting meetings with the goal of informing decisions about changing health policy, with the goal of this entire project to pave the way to allow insurers and health departments to adapt to using telehealth for monitoring medication adherence. And again, TB is our primary example because DOT is an acceptable form of treatment monitoring, but with the use of telemedicine or telehealth, we could potentially reduce a lot of the barriers that would now allow more effective monitoring of patients being treated for both infectious and chronic diseases. So with that, I just want to acknowledge all the collaborators that have been involved in this research from the beginning at UCSD and our collaborators at the Qualcomm Institute with the technology, our county health departments, our researchers in Mexico, and our partners at the Center for Connected Health Policy. So with that, I guess we'll open it up to questions.
Thank you, Richard. That was very, very informative, and you did a nice overview of the project that we're currently working together on. I did have a question for you. You had mentioned that there have been some elderly patients working on some of the projects or participating in the projects that you had conducted earlier, but is there sort of like, kind of like candidates that would be good for VDOT or candidates that wouldn't be good? What are sort of like the parameters that maybe a public health department might need to set out for deciding which patients would be good for using the technology?
Yeah, that's a really good question, May. I think that that our experience is starting to challenge our assumptions about using mobile technology for health. We originally had thought that we could identify characteristics of patients that would be good candidates for video dot, and so we in our research have been collecting information about prior experience using mobile phones and technology, age, literacy, language, being foreign born. And so far, none of that has really borne out as being good predictors of who can use the video dot. For example, we have one patient who was 86 years old. For 9 months. She made her videos every single day and was religious about doing it. And when it was all over, she said that she really enjoyed the experience and liked learning how to use the phone. Similarly, we had another 80-plus-year-old patient who had some tactile difficulty and just kind of couldn't manage the phone itself. He kept on deleting the icons because he was expecting to feel a click when he pressed on the buttons, and when he didn't, he held his finger there too long, and that makes icons get deleted. So with him, we retrained several times and ultimately decided that it wasn't the best approach for him, and he was returned back to in-person DOT. But what we have found is that in the beginning, the nurses at the health departments were somewhat reluctant and had their own biases about who it would and wouldn't work for. But the more they used it, the more they realized that, or the more that they were willing to at least attempt it with the majority of their patients. And then if it didn't work, then the option was to put them back on in-person DOT. And they just sort of were prepared for that. But I think a lot of the time they were surprised at how able patients were to use the technology.
Okay, thank you. We've got a question from John Kornak, and I apologize if I mispronounced your name. Are any of the store and forward sessions being reimbursed for VDOT? Do you want to take that, or do you want me to?
Currently reimbursed by insurance?
His question didn't specify, but I would think he would be asking about perhaps, yes, he's saying yes.
So as far as I know, all of the research that we've conducted with Store and Forward has been paid for by either the public or private funding that we've had for our research studies. So none of those events have been submitted for reimbursement. And as far as I know, there are no other health departments consistently using a Store and Forward method for delivering DOT. I know there are some counties that are using things like Skype and like a live VDOT, and I'm not sure if they're actually requesting reimbursement. I think in California they're using it, but they don't request reimbursement for those. But I can't say that there aren't other counties that that aren't submitting those claims for reimbursement. That's a really good question. Do you have any more information on that, May?
So currently, as far as Medicaid programs are concerned, there are 9 states in the United States that have Medicaid programs that reimburse for some Store and Forward. I would guess probably none of them reimburse for this particular thing. California's laws are set up where the decision can be made administratively within the Medicaid program for them to start reimbursing for this, but they are currently not doing it in California. I think Minnesota is also a state where they do some store and forward reimbursement, and we found out recently that at least the public health department is looking a little bit more into developing best practice guidelines for using telehealth to treat TB through DOT. So, but currently at this point, I would say probably no one reimburses for it, at least on the public payer side. Private payer side, you know, a lot of the private payers hold their policies close to the vest, but I would also say that that's probably pretty rare if, you know, if anybody is doing that. I would guess kind of nobody is. Okay, do we have any more questions? I have another one for Richard. Is, you know, what are some of the barriers that public health departments have come across, you know, trying to use this technology?
Well, probably the biggest barrier is the fact that it's a new technology, and shifting from paying salary for staff to buying phones and doing more with technology and less with human beings is, one, it's intimidating for the staff, and two, it's not easy to shift funds from personnel to other activities very easily. And so it takes time. It might be a year or so before a health department that decides that they want to adopt technology like this could identify the source of funding and then put it into perhaps the next year's budget. It's very hard to switch to something like this quickly. Then there's also the contracting process and determining whether this is a software package that a health department is going to buy, or a service that they'll subscribe to, or something that they want to develop in-house. And so it can take some time to figure that out. And then the other important consideration is the privacy issue and meeting the standards of HIPAA compliance. The rules are pretty clear, but then the implementation can be a little bit vague. And I think different health departments have interpreted the rules differently, and some are more stringent than others. So although a TB control program director might want to adopt the technology when they run it by their IT department before they get approval for the funding, that IT department, who might not understand or appreciate the use of it, may place strict criteria that would prevent them from being able to use it. I think those are the main ones.
Mm-hmm. And what type of training might, public health department staff need to go through in order to do this successfully?
Well, I think what's really helpful is for a health department to have already used in-person DOT. So they were already familiar with what they're trying to accomplish. And then when you put a new tool in their hand, like a mobile phone or a computer, and say, you're going to basically accomplish the same objective with this, then they kind of understand the concept, and then teaching them how to utilize the technology and determine how to verify that what they're seeing is actually what they want to see. It's fairly easy, but I think a good point is that the training has to be effective and thorough. And a suggestion would be that as health departments adopt this kind of technology, I think the best trainers are those who have already used it. So hopefully health departments can work together to do sort of a train the trainer and then share the information among them.
Great. Are there any other questions? I did have one last question, and most of this webinar has been on TB, but there's sort of other infectious diseases the technology and this application can be used for. I mean, what are some of those other conditions?
Mm-hmm. Well, basically, any disease or health condition where where you'd want to be sure that the patients are taking their medications completely and correctly could benefit from something like this. But then you have to balance out the burden that's being added to the patient to undergo this activity versus the benefit to using it. Now, in the case of TB, it's an airborne infectious disease that's deadly. And so there's a benefit to the patient to making sure that they're taking their medication correctly. And there's also a benefit to public health. And so it's worthwhile for the health departments to invest in this kind of activity. Now, if we can use mobile technology to lower the cost and the burden on the patient, now you can start to think diseases that you would never consider sending a doctor to a patient's home or a health worker to a patient's home to watch them take their pills. Now all of a sudden you might be able to do something in a very simple way that a patient would be willing to do, and health departments or doctors could afford to do. And so some examples of that might be this new treatment for hepatitis C, which is 12 weeks of a single daily pill that costs $84,000 would be one where you might really want to know that whether or not the patient is taking their medication every day. There might be some medications for serious chronic illnesses like diabetes or HIV, where you may not want to do this kind of monitoring forever for lifelong diseases, but maybe there will be periods of time when the patient is learning to take a new medication or is having some difficulty with adherence and compliance, where a provider might want to be able to monitor that patient a little more closely for a period of time. So I think that the range of diseases or conditions that could benefit from this type of monitoring is quite broad, and I think we're just now getting into really thinking about how much we can use this technology for other diseases.
Great. We got another question. Is this technology being used for any employee health TB testing within a health system rather than just for patient use?
So this is a video that's being shared with a provider. So I think if I understand the question, they might be referring to taking a picture or a video of the tuberculin skin test reaction and then sending that to the provider so that the patient doesn't have to come back 2 to 3 days after the skin test is placed. There are currently applications, and I think, May, you had touched on this, that in California, telehealth can be used for some applications, but not for TB yet. And one of them is dermatology. So if you can, take a picture of a rash and send it to your doctor, and then they can look at it, it could be used for this as well. I don't know of anybody that's doing that yet, but it's worth experimenting with.
Are there any more questions? No? Well, I just wanted to thank Upper Midwest TRC and Becky Sanders again for your help and for providing the platform for us today. Just a few last things. Get this advancing here. As you know, as I said earlier at the top of this webinar, the TRC monthly webinars do take place the third Thursday of every month. The next webinar will be held on August 20th, and it is being presented by the Pacific Basin Telehealth Resource Center. Just keep an eye on the Telehealth Resource Center website, and we will have more information regarding all these webinars. Because Becky is so wonderful, she will have a recording of this webinar up on our YouTube channel in about an hour, so you can go to that link to access it if you need to see something else again, or if you want to just pass it along to a person because you found this incredibly informative, as I hope you did, as I did. And one last thing, we have a survey that we would like you to fill out if you could. It is located on SurveyMonkey. It will very much help us out and help us plan for future webinars. And other than that, Becky, unless you have something else, or Dr. Garfien, if you have any closing words, I think we're done.
No, I'd just like
All right. Thank you, everyone, for participating.